The question reads, 15-year-old male is brought to the clinic by his mother. He has had non-pitting swelling of both lower limbs over the past 3 years. There's no scrotal swelling. He has no history of significant environmental exposures. Examination revealed woody edema of the legs with lichenification and hyperkeratosis. What is the diagnosis? 2. What is the organism responsible for this condition in West Africa? 3. How would you confirm the diagnosis in the side lab? 4. List 2 acute syndromes associated with this condition. 5. What is the role of doxycycline used in the treatment of this condition? So the answers. So the diagnosis here is lymphatic filariasis, which is one of the neglected tropical diseases. 2. The organism responsible for this condition in West Africa is the mosquito-borne filarial nematode called Wuchereria bancrofti, which accounts for up to 90% of cases. 3. How would you confirm the diagnosis in the side lab? So using the peripheral blood smear for thick and thin blood film, the films can be stained with hematoxylin and eosin or Gemsa stain, with the blood sample taken at night between 10 p.m. and 2 a.m. So list 2 acute syndromes associated with this condition. So the 2 syndromes here are acute adenolymphadenitis, which is characterized by sudden onset of fever and painful lymphadenopathy. It's also thought to be due to immune-mediated responses to the dying adult worms. Then the second is the acute dermatolymphadenitis, which is characterized by edematous inflammatory plaques and systemic symptoms like chills, myalgia, and headache. So this is thought to be as a result of superficial bacterial infection of the damaged skin. So what is the role of doxycycline in the treatment of this condition? So doxycycline is used to target the endosymbiotic bacteria called Wolbachia, which live within the adult worms and are needed for their reproduction. So targeting this Wolbachia will lead to halting the reproduction of the adult worms. It also improves mild to moderate lymphedema, which is independent of the ongoing infection. In addition, it can be used in the treatment and has a macrophyllaricidal activity. So I'm going to go over to an overview of lymphatic filariasis. Lymphatic filariasis is a neglected tropical disease caused by the nematode transmitted to humans through mosquito bites. The condition is prevalent in tropical and subtropical parts of the world, like sub-Saharan Africa, Central and South America, Caribbean, South and Southeast Asia, Western and Pacific regions. As at 2019, the condition affected over 120 million people in 72 countries. And in 2021, 882.5 million people in 44 countries were living in areas that require preventive chemotherapy to stop the spread of infection. Over 40 million individuals affected by the disfiguring features of the disease, with more than 5 million disability-adjusted life years. So the condition is noted to be the most disfiguring or debilitating condition after leprosy. So the prevalence in Nigeria, a study done by Waje et al. In 2017 put it at 11.18%. The infection is usually acquired in childhood, and there is a male preponderance, which might be attributed to the fact that males are more outdoors, and also the impact of the hormone testosterone, which encourage the growth of the adult worms. Filariasis can be classified into lymphatic filariasis, cutaneous filariasis, and body cavity filariasis. So yeah, I'm talking about lymphatic filariasis, which is caused predominantly by the Wuchereria bancrofti, which is seen mostly in sub-Saharan Africa. It can also be seen in Southeast Asia, Indian subcontinent, and the Pacific Islands, Latin America, and Caribbean. Bruguian malaria accounts for about 10% islands of Timor in Indonesia. Other kind of filariasis, the cutaneous filariasis, example, Loa Loa, Masonella streptoseca, Onchocerca volvulus, and body cavity filariasis like Masonella persistens and Orzadi. The risk factors include exposure to mosquitoes and from the bites, as we see in Culex mosquito, which is seen in mostly urban and suburban areas, Anopheles mosquito in rural areas, and Masonian mosquitoes. So also living in tropics and subtropical areas are risk factors. Travelers to tropical areas and some other activities like fishing and hunting are known risk factors. By way of the pathophysiology, filariasis infection occurs when a larva carrying the mosquito bites an individual, introducing the larvae into the skin. The larvae enters the patient's blood through skin wounds and spread to different sites, such as the lymphatic vessels, subcutaneous tissues, and serous cavities. At these sites, the larvae matures in 6 to 12 months period into an adult and can live up to 15 years in the lymphatic system. The pre-patent period, which is usually about 12 months, is the period from the introduction of the larvae to the maturation to the adult stage. So the life cycle usually takes place in the male, between a male and female adult worm in the infected human host. They produce microfilariae, which are premature worms with sheaths. And this sheath helps them to move within the vessels and the lymphatic system. So the microfilariae circulate in blood and are picked up by the mosquito during a blood meal, and they lose their sheaths to form the larvae that infects the humans during a blood meal. The larvae migrate to the lymphatic vessels where they develop into the adult worms, thus continuing propagating the cycle of transmission. So this is just a diagram explaining all what I've said. So you see from the infective stage, which occurs in the mosquito, the L3 larvae, you can see that the mosquito takes a blood meal and injects the worms into the L3 larvae into the adults. So it matures and gets it to the adults, male and female, which reproduce to produce the microfilaria, a lot of microfilaria. These sheeted microfilaria, they migrate to the lymph and the blood channels. And when the mosquito comes in, another mosquito comes in to take a blood meal, it ingests this microfilaria. So the microfilaria then goes to the midguts and migrate to the thoracic muscles of the mosquito. Then develops into the L1 larvae, L2, then L3 larvae, and this then migrates L3 larvae, which is the infective filaria, then goes to the head and the mosquito proboscis. So when the mosquito injects this microfilaria into the human, it then propagates the cycle. So it's like a vicious cycle. It starts again. So you can see both the adult female and male worm. So you see that the adult female worm, the tail is pointed as against the male, which is curved. And you see that it's longer. Yeah, the adult female worm. So this just explains the life cycle. So there are other factors that are involved in the pathogenesis of lymphedema and progression to
just trying to summarize.
Okay, the duration of so I'll just, because of time, I'll just go over to the clinical features. So the clinical course is divided into 3, the asymptomatic microfilariemia stage, which And then the acute phase of the adenolymphadenitis, then the chronic irreversible lymphoedema, which this patient, the index patient, presented with. So these are the features. Then there's a staging that helps to stage the lymphedema. So this index patient is in the stage 4, which is lymphostatic lymphatiasis of the or the deformation of the limb due to the extensive swelling, skin thickening, scarring that is seen. So we talked about the various acute syndromes. The other ones include the filarial fever, tropical pulmonary eosinophilia, which is caused by the immune hyperresponsiveness to the microfilaria trapped in the lungs. So you can have dry paroxysmal cough, wheezing, dyspnea, anorexia, malaise, and weight loss. So other investigations here, the blood is taken at 10 p.m. to 2 a.m. and you can check for the circulating filarial antigens to diagnose the Wuchereria bankruptcy, which can be done as point of care tests. PCR is like the gold standard, but mostly used in research. Other tests, urine, can also check microscopically for the caliuria and also the microfilaria in the urine. And this is just the worm in the peripheral blood smear. Then other investigations, serology, full blood counts, which will show eosinophilia, elevated serum IgE, histology, which will demonstrate the fibrosis and lymphatic obstruction of the blood channels, hyperkeratosis, acanthosis, and lymphatic tissue. So the differential diagnoses are a lot. As you can see here, because of want of time, I might go over this. And then the treatment is to kill the adults. The goal of treatment is to kill the adult worm, eliminate and manage symptoms, then eliminate and reduce transmission of filarial infection. And it's important to know that multidisciplinary approach is very important here in the management. So the treatment of choice is the diaetic carbamazine. However, it's contraindicated in patients co-infected with onchocerciasis and must be used in caution with patients with lorasis. Then the monoinfection would be to give, if there's absence of onchocerciasis or lorasis, you should receive a single dose treatment of 6 mg per kg, regardless of whether the clinical symptoms or microfilarioma are present. You can also give this medication for 12 days as well. Additionally, you can add doxycycline 200 mg per day for 4 to 6 weeks, which is microfilaricidal and help in the edema. Then the other treatments, if there are co-infection with onchocerciasis, ivermectin is recommended at 150 microgram per kg per single dose to clear the onchocercal volvulus. Also, alternatively, you can also give doxycycline if there's lower co-infection and if it's less than 2,500 microfilaria per ml of blood, you treat with diacetyl carbamazine using the standard regimen for 21 days. Then patients with higher levels, you can, which is up to 20,000, you give pre-treatment with ivermectin to reduce the microfilaricidal load prior to the administration of the diaetic carbamazine. Then patients with loads greater than 20,000 microfilaria per ml should be treated with albendazole 200 mg orally BID for 3 weeks and doxycycline 200 mg daily for 4 to 6 weeks. So you don't use the contraindicated in patients if the lower load is greater than 30,000. Then also it's important to take into cognizance psychotherapy for this kind of patient because of depression, nutritional support for these patients. Fatty foods are restricted in individuals proven to have the caliuria. Then also you treat other nutritional deficiency. So surgery is also indicated to debulk the skin and create lymphovenous anastomosis to improve drainage. Then the complications, these are the complications. Then the prognosis is good if the infection is recognized and treated early. So long-term disability may result from chronic lymphatic damage. Then control, mass drug administration for preventive chemotherapy is the mainstay of control. WHO has launched a program in 2000, and since then, 17 countries have eliminated the disease, and the global population of the infected persons has declined by about 74%. Supplemental strategy include vector controls using insecticide-treated nets, indoor residual spraying, or personal protection measures, which can help. So the prevention is in the primordial prevention, primary prevention, secondary prevention, and tertiary prevention. So for secondary prevention, as advocated by the World Health Organization, is to give albendazole 400 milligram alone twice per day for areas co-endemic with filariasis, ivermectin 200 microgram per kg with albendazole, that is 400 milligram, in countries with onchocerciasis. Dietary carbamazine can be given with albendazole in countries without onchocerciasis. And then ivermectin 200 microgram per kg together with dietary carbamazine citrate and albendazole, that is triple therapy, in countries without onchocerciasis where other programmatic conditions are met. So tertiary prevention is to do appropriate management of complications, hydroxy, the morbidity management and disability prevention, and then rehabilitation. So the key points to note here are that is a neglected tropical disease, can cause lymphatic, the Wucheria bankruptcy can cause lymphatic filariasis, and the levels are known to peak at night, 10 p.m. and 2 a.m., where samples are collected for the diagnosis. Then for filariasis, levels peak between 10 a.m. and 2 p.m., which is quite different from the lymphatic filariasis. Capillary pinprick can be used to take samples for the blood testing. And the first line treatment is the dietary carbamazine. But when onchocerciasis there's co-infection with onchocerciasis, ivermectin should be used. So this just in summary explains the various organism, their periodicity, the vectors, and the location of the adult worms. So these are my references. Special thanks to Dr. Adewale Ogundare, Dr. Ifemwa Ede, Dr. Rukaya Sani, and Dr. Ekele Roberts. Thank you.
Thank you so much, Dr. Paul, for the beautiful presentation. Thank you so, so much. Okay, so now we'll take comments and questions from the participants first before our teachers come in, and let's leave the things coming on the chat. Okay, so there's a hand up. Dr. Kalamama, please go ahead.
Okay, thank you so much for that extensive presentation. Just an add-on to what you just did. Okay, so doxycycline also has an anti-inflammatory effect, and how this happens is that it actually inhibits the vascular endothelial growth factor, thereby inhibiting what the inflammatory cytokine, that's interleukin-4. So that's how it actually has that anti-inflammatory effect. So it actually inhibits the vascular endothelial growth factor, indirectly inhibiting the interleukin-4. So that kind of takes care of the inflammatory response that can actually occur in this patient. Then again, in the aspect of the prevention, as you mentioned, that the filarial worm can actually stay as long as 15 years in the lymphatics. Then in the entire body, can actually survive for over like 8 years. So in preventing these infections from spreading more in the community, so what we do is that a mass deworming will be done on them, whereby they get the medications once a year for like 6 years. So this will help to get rid of the population with the entire disease. So you give the drug once a year to the entire population where you have the endemic, where it is endemic, you give them the drugs once a year for 6 years, and that will take care of the population who entirely have the disease. Thank you so much. That's all I can say. Thank you. You did a great job.
Thank you, ma.
All right, thanks so much, Dr. Florence. Thanks so much for that addition. Okay, so you have a lot of thanks on the chat. Thanks from Dr. Lighton. Dr. Onelum says, thank you very much for the beautiful presentation. I think tropical pulmonary eosinophilic syndrome should also be considered as syndrome associated with so tropical pulmonary eosinophilic syndrome should also be considered as syndrome associated with the disease. And please, why is DEC contraindicated in lower and onchocerciasis? Dr. Paul, do you want to react to that?
Okay. Hello?
Go ahead, I can hear you. Go ahead.
Yeah, because of the side effects for DEC is usually, I think it causes a reaction, Mazzotti reaction. So typically you don't give, because of the hypersensitivity to the microfilaria, so it can cause a life-threatening anaphylactic reaction. So typically you give DEC for lymphatic filariasis caused by the Bancrofti worm. So lower, and what is recommended is to give what is recommended for lower is to give the other therapy, not diatic carbamazine, because of that effect. I think that's what I have to say.
Okay, thank you so much. Okay, so Dr. Blessing Azuko says thank you. Dr. Puti says thank you. Dr. Ifeoma, Dr. Becky Obasi, Dr. Justice CBT, Dr. Adobe Obiefuna, Dr. Rita Lako, Dr. Adiboka says thank you. I also thank you. Dr. Temitobo says thank you. Dr. Mbapita says thank you, sir. Excellent presentation. Is there a rule for the fortification of household salts with DEC?
Yes, I think I saw something like that. Yes, you can use DEC. You can use fortification with salt when giving DEC. Mass drug administration as well.
All right. Dr. Musa says thank you for the beautiful presentation. Dr. Bifiri Hart says thank you. Dr. Yahya Mohammed says thank you for the beautiful presentation. One of the investigation is ultrasound scan for lymphoscintigraphy. Is there a role of surgery in the treatment?
Yes, I think I pointed that. So you can do surgery especially to correct if there's a large hydrocele or scrotal lymphatiasis, you can manage it with surgery. Then also if there are to debulk the tumor and then create anastomosis for drainage, you can do that. However, surgery is shown to be less successful. I mean, may necessitate multiple procedures and skin grafting. So, but it's also an option in the management, especially when they have lymphatiasis.
All right, thank you so much. Okay, so Dr. Ifeoma says both Bridger and Wuchereria cause lower limb lymphangitis. Wuchereria Bancrofti particularly affects the genital area. All right, thank you so much. Dr. Mamodu says thank you so much for what is pre-patent period, and then what is the average duration of the pre-patent period? That's his question. Okay, go ahead.
Hello? Okay,
go ahead.
Okay, the average duration of the pre-patent period is sorry, I'm coming. Okay, the pre-patent period is usually about 12 months from the period from introduction of the larvae to the maturation to the adult stage. That's about 12 months, the pre-patent period.
All right, thank you so much. So his comment, 2/3 of cases worldwide is by Brugia malayi. Really? Lymphoscintigraphic techniques can be used to detect the presence of adult worms in lymphatic vessels. Living worms tend to be in continuous motion, which can be detected on ultrasound. This has been described as the filarial dance sign. Well, thank you so much, Adon. Thank you so much. Okay, Dr. Ifeoma says other management strategies: antipyrexics, analgesics for acute cases, antibiotics for secondary bacterial infection. Then, could this be Brugian filariasis, considering the absence of scrotal involvement? Here, even though bankruptcy is most common in our environment. Okay, she's asking. She's asking if this could be Brugian.
It can affect it doesn't mean that the Wucheria bankruptcy can also have lower limb elephantiasis. Yes. So it's a differential actually, but top on the list because of how common it is in 90% of cases, especially in sub-Saharan Africa. And that's why I chose Wucheria bankruptcy. Yes, but it's a differential as well.
Okay, then Dr. Mahmoud is adding from bite to diagnosis the pre-patent period. Okay, thank you so much, everyone. I don't know. I wanted to ask if you came across the reason why it's more common in children. I think I saw one that it could be a transmitted transplacental from the mother to child. I don't know whether you came across other reasons why it's more common.
Other reasons: children are more outdoors, playing outdoors, so the infection usually would start from in childhood, and you see that most of these patients, they are asymptomatic. So it starts in childhood, and later on, sometimes it even presents. The first presentation, symptomatic presentation, might be in adulthood or early in the teens. Like this patient now, he's 15 years old. Yeah, so usually they start in childhood.
All right, thank you so much. Okay, so I'll hand over to our teachers, Christabel.
Oh, thank you, Dr. Kele. Thank you so much. I must appreciate the speaker, Dr. Paul Lewanta. He did well. I think he answered the question well from my own end, and I must appreciate Dr. Mamudu, Dr. Kalamama, and every other person, Dr. Neka, and every other person that contributed. I think the question has been answered actually. And whenever you are giving questions in exam, please don't be asking yourself unnecessary questions. Just answer the questions they give you and then move forward. So overall, it was a wonderful presentation from my end. Chief Banse, Koki, Chitu Remigo, Sokopi, Fatima Abdullahi, Dr. Success, Dr. Okute, Dr. Yahaya, any comment? Okay. Think we don't have any comment. Yes.
I was really impressed.
Thank you. Yes, it did well. It was quite eloquent. Dr. Paul, thank you. It was quite a detailed presentation. Showed you did your research, quite elaborate, really. It was elaborate. Thank you. I appreciate you as always appeal. Please keep speaking in class. Thank you. Thank you. Thank you.
Thank you very much.
Thank you very much. So we will take the second presenter. Dr. Kele, over to you.
All right, thank you so much, Ma. Thank you, Dr. Paul. Thank you, everyone, for your comments. Dr. Raleigh, please, can you share screen?
Okay, good morning, everyone. Can you see my screen?
I can see it. I can see the presentation yet.
Can you see it now?
Yes, I can see it now. Okay, so you can.
Hello.
I can see it.
Hello, please, can you hear me?
I can see it.
Can you hear me?
I can hear you. I can hear you. I can see it too. Can you put it on slideshow?
Okay.
It will be difficult. I think we can manage it like this.
I think it will be difficult because I'm actually using my tab.
All right.
No, just click on play. I
can
can see
actually
play up there. Click on play up there. After, yes.
Thank you.
All right.
Good morning,
It's good now.
my teachers, and good morning, my teachers and colleagues. I'm Dr. Mabuwari, and I'll be taking. Please, can you hear me? Hello, can you hear me?
You were breaking, but we can hear you better now.
Speaking on station 3B, and the question reads, what is diabetic ketoacidosis? How do you make a diagnosis? B is, how do you make a diagnosis? C, what are the current ways of managing it? D, what define diabetic foot syndrome? E, outline the management of diabetic foot syndrome. So for question A, diabetic ketoacidosis is an major life-threatening complication of diabetes mellitus, and is characterized by hyperglycemia, ketoacidosis, and ketonuria or ketonemia. And this is more predominantly seen in patients with type 1 diabetes mellitus, and it occurs when there's absolute relative deficiency of insulin. So the big question is, how do you make a diagnosis? Diagnosis is made based on history suggestive of hyperglycemia, of physical exam, and investigation. The investigation which shows acidemia, evidence of acidemia, or where there's bicarbonate levels of less than 15 millimoles per liter, or venous blood pH of less than 7.3. And there's hyperglycemia, blood glucose is greater than 250 milligram per dl, ketonemia, there's lactate levels greater than 3 millimoles per liter, or there's significant ketonuria on 2+ is on dipstick, urinary dipstick. So being more on detail, from the history, there'll be symptoms suggestive of hyperglycemia and the polyuria, which will be polyuria, polydipsia. They can have nocturia or weight loss, and they can have patients will also have be present with weakness, malaise, and there will be evidence of a precipitant, being maybe for an infection. If for urinary tract infection, they could have maybe dysuria or suprapubic pain, or if there's evidence of chest infection, because these are more like the common infections as precipitants for diabetic ketoacidosis. So they can have cough with sputum production, they can have tachycardia, there may be fever. Then on examination, they could have these cosmal breathing, or we should have this deep sign respiration and evidence of acidosis. They could have this fruity smell, acetone breath. They could have nausea, vomiting, or abdominal tenderness, as which is usually non-specific. And then they could have this impaired level of altered sensorium, impaired consciousness in about 1 in 5 of them. So the C question is, what are the current ways of managing it? So the principles of management, usually managing patients with diabetic ketoacidosis is multidisciplinary, and these patients are preferred to be managed in the intensive care unit or the high dependency unit. So we want to, the principles will include correction of the fluid losses because they are really dehydrated, then correction of the hyperglycemia with insulin. They want to manage electrolyte derangement. So want to identify and treat the precipitant that is where they maybe different precipitants if it's infection. I want to treat prophylaxis with prophylaxis for DVT. Then, of course, very importantly as well, patient education. So for the fluid, be more specific. We want to use an crystalloids isotonic fluid to replace what the patient has lost, and it's assumed that they've lost up to 6 liters of fluid. Then an initial, we want to give 1 liter during the first hour, 1 liter over the second hour, and 1 liter over 2 hours. Then depending on the patient's hydration status, that one to guide the fluid administration. The goal is to replace half of what the patient has lost at least half of what the patient had lost within a period of 12 to 24 hours. Then as regards the insulin administration, we want to give, depending on the body weight, but using at 0.1 units per kg per body weight intravenously. Then we want to do a continuous infusion at a dose of 0.1 units per kg per hour. There's been this guideline from the Joint British Diabetic Society that recommend that using a weight-based feast rate until the ketonemia subsides. So depending on if the patient is conscious or not, that will depend if we're going to use an insulin infusion or if the patient can feed. We want to use a subcutaneous insulin administration. The target is to optimal glucose reduction of between 3 to 4 millimoles per hour. For regards to potassium replacement, if the potassium level is more than 5.5, you don't need to add any KCl to the infusion. If it's between 4.5 to 5.5, you add 20 millimoles into each infusion, 1 liter of infusion. And if it's between 3.5 to 4.5, of course, to use 40 millimoles into each liter of infusion. Then for bicarbonate, routinely, as the hydration status is being, the dehydration is being corrected and the blood sugar level reduces, the bicarbonate corrects itself. Rarely, they've had to use bicarbonate therapy in some occasions, but most of the time the acidosis corrects itself. Then if there is cerebral edema is suspected, of course, we want to use an osmotic diuretic to monitor. Well, of course, the precipitants, want to address the precipitants. If it's infection, role of antibiotics, but more commonly, non-compliance with medications is also a very common precipitant. So this is where patients' education comes in. We want to advise them about the need for regular monitoring of their blood sugar, as well as lifestyle modification, diet therapy, as smoking, reduce alcohol intake, and then re-emphasizing the need for compliance. Then also the role of prophylaxis against deep vein thrombosis. The D question states that define diabetic foot syndrome. According to the World Health Organization, diabetic foot syndrome is defined as ulceration of the foot distally from the ankle, also involving the ankle with associated neuropathy and different grades of ischemia or infection. And this can be due to several factors, could be for inappropriate, some risk factors for DM foot syndrome could be use of inappropriate footwear, poor glycemic control, evidence of other complications of diabetes, and also when there's abnormal conformation of the foot. So in sense, we're talking abnormalities or joint immobility as risk factors. So for the question D, you talked about the next question talked about how the modalities of management, outline the principles of management. It states the American Diabetic Association has stated, made a consensus statement that the management of diabetic foot syndrome is multidisciplinary, involving the endocrinologist, the podiatrics, the vascular surgeon, orthopedic surgeon, the nurses, the podiatrics, and the principles will include offloading of the wound, bed rest, very important, a debridement to ensure that the wound heals well, so we'll have healthy granulation tissue, wound dressings, depending on the severity of the wound, we want to use saline dressing or honey USOL dressing, glycemic control, appropriate use of antibiotics, revascularization by the vascular surgeon to correct any peripheral arterial insufficiency, then DVT prophylaxis, limited amputation, that's using prosthesis, then identify and correct risk factors. There's a mnemonic, Godwal, Godwal is a mnemonic that can be used. I think we had an earlier presentation on DM foot syndrome where there's this ICS code that was given. Still, these same principles are listed, but any one of them can be Godwal, good glycemic control / correction of anemia and metabolic derangements, offloading / bed rest, debridement, DVT prophylaxis for D, wound dressing for W, A, appropriate antibiotic therapy, R, revascularization, L, limited amputation, P, patient education. So I'll just bring in some more information about diabetic ketoacidosis.
Okay, Chief, you have 1 minute. Can you just rush through it?
Okay, I'll just quickly rush through it. More importantly, we need to understand the role of insulin increasing glycogen synthesis as well as decreasing gluconeogenesis. So anything when there's in type 1 diabetes, we already know that. Okay, I'll just mention the precipitants. Insulin insufficiency as seen in newly undiagnosed diabetics, or there is non-compliance for those that are already non-type 1 diabetic, any form of infections, infections like pancreatitis, some medication use, toxins, amphetamines, that are sympathomimetic agents, amphetamines, cocaine, and also iatrogenic use, patients on steroid medication, either transplant patients or other patients on steroid medications, and also surgery. So in understanding the pathogenesis, anything when there is decreased insulin, absolute or relative insulin deficiency. So it means that insulin is not, there's reduced insulin levels. So there'll be hyperglycemia, which can be from decreased utilization of glucose by the peripheral tissue. There's increased gluconeogenesis. And so with this hyperglycemia, it will cause glucosuria, osmotic diuresis, dehydration, and electrolyte losses, as well as increased lipolysis, which will bring about the increased ketoacid, acetoacetate, and the others that will be seen in the blood as well, and also in the urine. So this is just a table that is trying to give a summary of the pathogenetic features, a graphic, a representation, a pictorial diagram showing the pathogenesis of diabetic ketoacidosis, as well as the clinical features which are talked about. The diagnosis are talked about. This is there's infection. If there is anything, if there is electrolyte derangement, of course, you can see that from our EU creatinine. Infections from blood, urine cultures, microscopy culture, and sensitivity. And of course, if we want to request for the glycated hemoglobin, if this attack is a result of poor control, of course, the glycated hemoglobin will come in. So this slide is showing the grades of diabetic ketoacidosis: mild, moderate, severe. Just because of time, I think we could look at that and try to compare that with HHS and seeing in terms of the glucose levels. Glucose level is far higher, and the mental state of the neurological manifestations is more in patients with HHS compared to patients with DKA. But in more severe form of DKA, the mental level of neurological involvement may almost be the same for severe DKA and HHS. For principles of management, I already talked about this. Then the flow therapy, this is just more a substantive flow therapy in management of diabetic ketoacidosis and DKA, which are more like complications, could be shock from treatment, cerebral edema, of course, this will be treatment related, and also hypoglycemia. If we are being over judicious use of insulin, they could have hypoglycemia as a conclusion of treatment. It could have acute renal MI, all this could cause morbidity and mortality. So this is just a HHS, just because of time. We could go over this later on. Thank you very much. And very importantly, I'd like to appreciate Dr. Ogangba's success, one of my chiefs who had made a presentation on this earlier. Slides came in very useful. Thank you very much for listening.
Thank you so much, Dr. Raleigh, for stepping in. Thank you for the beautiful presentation. Okay, so now we'll take comments and questions from the participants first, and then our teachers will come in, and let's keep the thanks coming on the chat. Okay, so there's a hand up. Dr. Kalama, please go ahead.
Okay, thank you so much. That was a beautiful presentation. Okay, just an add-on to what you said. Okay, so in the principles of management of diabetic foot syndrome, I think you forgot to add pain management for this patient, and also prevention of reoccurrence. The other foot may be at risk, and aside that, to prevent it from reoccurring, so we are supposed to educate them on foot care, where you tell them to check their feet daily for any change in color, look for signs of infection. They have to wash their feet and clean it and keep it dry as well, and then moisturize the feet daily. Then also you tell them about if they have to cut their nails, they should actually cut it straight and then avoid the filing the nails. And also they're advised to not to cut their nails themselves. Maybe they have to have someone who can cut their nails due to distal numbness, that's due to peripheral neuropathy. Then they should also wear shoes, supportive shoes that can actually fit well, either maybe 1 or 2 inches in front and behind. And then they should also check their shoes before they wear them to make sure there are no sharps. And also they should maintain good glucose control, and then do a yearly diabetic foot screening every year. Maybe do arterial Doppler to make sure there's no form of peripheral neuropathy that can lead to vascular ulcers. So that's just an add-on to the principles of management for diabetic foot syndrome. Thank you so much.
Wow, thank you so much, Dr. Kalama. I
Thank
also
you.
add to the food care, no warming themselves close to fire or warming their food in warm water or hot water. I think I've had a patient who did that. Just to add to that. And then also, let me just make my own comment also. Talking about the potassium management, potassium is usually given over 4 hours. So I was wondering, if you're to correct potassium, you're supposed to give the first liter in 1 hour. I think you said, did you say 1 hour, 30 minutes? 1 hour, then the second liter in 2 hours. Okay, 1 hour. So I think I asked an endocrinologist once. They said, okay, if you have to do that, then you have to set 2 lines and put the potassium on the other hand, on the other line, and then do your fluid correction on the other hand. I think that's the answer I got. Okay, so let me go to the chat now.
Before you go to the chat, just those people, their hands have been up. Just take them. Then.
Okay, Doctor, sorry, please go ahead. Sorry, I didn't see those. Doctor, sorry.
Yeah, morning, everyone. Thank you very much for the presenter for a very good presentation. Just a few things to add to the diabetic ketoacidosis management. So when you have a situation of severe hypokalemia, potassium less than 3.3, you actually have to hold on to the insulin and correct the potassium before giving the insulin, because as we all know, giving insulin moves more potassium into the cells. So you can get life-threatening hypokalemia if the potassium is less than 3.3, and then you start giving insulin. So you would give potassium 20 to 40 ml equivalent per hour, and then get the potassium above 3.3 before you start the insulin in patients with severe hypokalemia. And then also those who have severe acidosis, there is indication to give them sodium bicarbonate. When the pH is less than 6.9, sodium bicarbonate is indicated to bring it to above 7. And then you can continue with the fluid replacement and insulin for total correction of the acidosis. Thank you very much.
Oh, thank you so much, Dr. Conte. Dr. Omokowa Asekama.
Thank you, Dr. Kelly. And thank you, Dr. Rowley. Thank you for the opportunity. I have a mixture of comments and questions. Let me just start from the last Dr. Kalamama's comment. I want to just maybe modify it a bit. I think that diabetics are usually advised not to perform their own inspections. They don't perform foot inspections themselves, and they don't perform shoe inspections themselves, because the microvascular complications of diabetes are believed to bunch together at most times, so they could have retinopathy. So it's believed that somebody else should always do the foot or shoe inspections for them. Then, I don't know if the patient has vasculopathy, which I think a good number of them have. It's usually recommended that some medications used for peripheral artery disease could be used in them. So medications like pentoxifylline, silastazole, which are actually very much available in Nigeria now. It's different from it used to be. And then I don't know so much about this, But we were also taught then as residents that there are new dressing techniques, wound dressing technique. I believe this is within the purview of the surgeons, but there's a lot of more than maybe just normal saline and honey that they do these days. They do vacuum dressings, they do hydrogel, they do biofilm dressings. I'm not using the correct word. An example is this agent called biodress. So these biologic dressings actually contain organisms that can actually break down dead tissue while promoting the growth of healthy tissue. They are dressings such as that. And I have a few areas where I'm still gray with management of DKA. One of them raised was that of cerebral edema and the role of mannitol, and I believe combined with furosemide. I don't know what impact that has on the blood glucose control based on our experience and based on what the books say, because I heard the presenter mention using mannitol if there's cerebral edema. And then also, if the patient had already been on a long-acting insulin, in the setting of DKA, do you have to discontinue the long-acting insulin, or you continue it along with your management for the hyperglycemic crisis? Thank you very much.
Thank you so much, Dr. Sekame. Okay, go ahead, Dr. Roddy. You can react.
Okay. All right. Thank you very much for the comments and the question. About cerebral edema, as much as possible, we want to try to not be active with our fluid administration, so we don't have that complication, as cerebral edema is a complication of treatment. So when a patient has cerebral edema, there are different options of management. First of all, held teeth 30 degrees held up is one of the management of cerebral edema. Then the use of osmotic diuretic like mannitol being used for the management of cerebral edema. Now, depending on the dose of your mannitol, that will now indicate, or if you are adding on your furosemide. If you are using a loading dose, depending on the weight of the patient, you should use furosemide. But if you are using at maintenance doses, this is center specific actually. At the maintenance doses, you don't need to add on furosemide. So we'll start on with reading the held up tilt at 30 degrees is a management protocol. Other management options will now have use of your 20% mannitol. Now, dose of furosemide add-on is dependent on how much of 20% mannitol, the volume you are giving to the patient. And then the other question, the other question about, sorry, I didn't get, there was another question.
Okay,
about, yes, yes, I remember now, about long-acting insulin. If in the setting of DKA, you are using your short-acting insulin, short-acting soluble insulin. It's at the point where you have maybe gotten your values, maybe less than 40 millimoles, or some centers will say 10 to 12 millimoles per liter. That's around 180. Some centers will tell you when it's less than 250 milligram per DL. This is 250 milligram per DL. This is from the updates, the last updates, DKA presentation, less than 250 milligram per DL. Then you now want to convert. Are you now going to give subcutaneous, or you want to use an infusion? That's dependent on if the patient can tolerate. The word is tolerate orally. So now depend on where, but at that acute time, you are not using the long acting like the glargine insulin and the others during the acute period.
Thank you.
All right, thank you so much. Okay. I can't see. Okay, there's Dr. Araga, please go ahead.
All right. Good morning, everyone. Thank you, our facilitators and colleagues. Okay, just to respond to the question on long-acting insulin. So for a patient that is already on basal insulin, that is a long-acting insulin, and now has DKA, you continue with your basal insulin. The patient has to continue with the basal insulin while you titrate the soluble insulin. Now, the dose of 10 units, there's a general rule to it. You just use. Hello? Can you hear me?
I can hear you.
Okay. So use 0.1 international units per kg per hour. That's the dose you use. So if a patient is 10 or 100 kg, then you are using 10 international units per hour. Okay. Then when the blood sugar drops to 250, less than 250 milligrams per dl, you step down the dose to 0.05 international units per kg. Because at that point, you want to avoid hypoglycemia while also you continue the titration to ensure that ketonemia is taken care of. Thank you.
Thank you so much, Chief Aragai, an endocrinologist. Chief, please, how are you giving the 0.1 international unit per kg? Is it IM, is it IV, is it
No,
sub-Q?
IM administration at this point is not advisable, it's not recommended. You do IV because this patient presents to you dehydrated. So when you give IM, absorption is impaired. So you do IV titration. So we have a variable rate infusion or fixed rate infusion. So you put if you have an insulin pump, you use an insulin pump to titrate. Okay, but if you don't have an insulin pump, what we do in our environment is a Soluset. Okay, so your target drop is about 3 to 4 millimoles per liter of insulin per glucose per hour. Okay, so you have to set 2 lines actually. One line used for insulin titration, the other line on the contralateral arm is for IV fluid administration. Thank you.
All right. Thank you so much, Chief. Okay, I can't see any other hands up.
Dr. Kele,
Ma'am?
Dr. Kele, because of time, we are really behind schedule, but the plan was to end 8 on dot. We're already behind schedule. We just keep the stand, just go straight to the questions and comments.
All right, Ma. Okay, so thanks for the presentation. With regards to the potassium correction, what is the frequency of this infusion you would like to give? Is there a maximum dose per unit time? At what point during the correction will you commence potassium correction? Really, I don't know if you got that.
Sorry, can you say that? I didn't get that.
Okay, so with regards to the potassium correction, what is the frequency of this infusion? I think like how often do you give, or how many potassium infusions will you give? Is there a maximum dose per unit time? At what point during the correction will you commence potassium correction?
Okay, thank you very much. I mentioned that when I think they had this, you give it, if the potassium level is greater than 5.5, you don't need to give any potassium. If it's between 4.5 to 5.5, 20 millimole into each 1 liter of infusion. Then
so when you say each 1 liter, is it like if you give up to 6 liters, you put it in the 6 liters? I think that's what he's asking.
No, because these patients' electrolytes will be told. You are going to have serial monitoring. So because you're not starting you don't have it. By the time you are checking the patient's blood glucose, you are not starting your potassium correct points because you will not have your electrolyte, urine, and creatinine results at that point. So it depends on the values that you are seeing because you're going to have your serial monitoring of the patient's electrolytes.
All right. Thank you so much. So thank you for Dr. Rita says, thank you for the presentation. In severe hypokalemia, replace the potassium before insulin therapy and also ensure adequate urine output before starting potassium replacement. Thank you so much, Dr. Rita Laco. And then Dr. Mark says, thank you, Dr. Rowley. How do you make a diagnosis? Blood glucose greater than 250 milligram per DL, arterial pH test less than 7.3, sodium bicarbonate less than 15 milliequivalent per liter, and then ketonemia and ketonuria. Okay, and then for the DMFS, you can give IMTT 0.5 mils. Thank you so much, Dr. Makri. Dr. Ademipe is adding what's the expected rate of reduction of serum glucose and ketone per hour with treatments in DKA. So what's the expected rate of reduction?
That was stated. I mentioned it that when it's the rate of reduction per hour for glucose is between 3 to 4 millimoles per liter or 50 to 70, which is equivalent to 50 to 70 milligram per dl per hour. That's the expected rate of reduction. For the ketones, I'm not quite sure about that.
All right, thank you so much. And Dr. Momodu is adding cerebral edema most common amongst younger persons. Mannitol or 3% saline, hypertonic saline, can be used as it increases plasma osmolarity, causing an osmotic shift of water out of the brain cells. And Dr. Onyegwim is adding, just asking, how do you give 0.05 IU per kg per hour when the glucose level is less than 250 milligram per dl as suggested in glucose infusion? Okay. Okay. Let me take the next. Go ahead if you want to. Go ahead.
Okay, I thought the question was already addressed about, I think that's where you use an insulin pump. Okay. Insulin pump. At the point where the blood glucose is less than 250 milligram per dl, you need to assess if a patient can tolerate orally. If a patient can tolerate orally, you can now want to start giving your subcut, and you're sure that the patient is well hydrated enough, you start giving subcut insulin. If a patient cannot tolerate orally or is not conscious, there's altered sensorium, you now want to give your glucose infusion. So you're putting your insulin as an infusion to be given. Insulin with your glucose.
All right, thank you so much. So Dr. Omokowa is also adding, also, is a high anion gap acidosis a requirement for the diagnosis, or is it variable? Okay, I think because of time, I think we can answer the remaining on the block. Let me hand over to our teachers now. Because of time, please post the questions on the block on the chat. Okay, Christabel, please go ahead.
Thank you, Dr. Raleigh. It was quite a wonderful presentation. I think Dr. Manza is in class, the Chief Bansi is in class, our endocrinologist. I don't know if any comment before we close the class finally.
Hello, Christopher.
Yes, I can hear you, sir. Any comment?
Sorry. I'm busy right now. I won't be able to talk.
It's fine. It's fine. Thank you, sir. So the presenter did well. I love the way she answered most of the questions, the comments, the questions. See how active the class is becoming that we even have to beg people to close the class because it's past 8. Once past 8, people get into different meetings and different activities. So attention is divided. So we don't get the full benefit from the discussion. So that's why most time I usually encourage us to close before 8. So thank you, everyone. Thank you, Dr. Raleigh. Please, before we close the class, I want to quickly announce that we have a class rep for the national guys. The national exam will be coming up in November. So I want to announce the class rep. The class rep is Dr. Temitokwe. She's a pulmonologist, a boarding pulmonologist. So she will help us organize the national guys, get their names, get a list of people going for the exam, and organize our colleagues. So Dr. Temitokwe, don't know if you have any comment to in the class.
Good morning, teachers and colleagues. I would just want to say thank you for the opportunity and greetings to everyone. Thank you.
Thank you so much. Thank you for accepting to help us coordinate the class. We really appreciate you. Being the class rep can be quite sacrificial. I must appreciate Dr. Atta, Dr. Yahaya, Dr. Fatima, Dr. Kopi, that have set the pace. These guys have taken the class rep into something else. Dr. Ekele has stepped in and Dr. Kalamama. So I know from the past history with you, I know you do excellently well. So thank you so much. We are grateful. Chief Chitu, sir, please can you help us close the class?
Hello, Dr. Christopher. Good morning. Yeah, sorry, I was driving to reach for my phone. Okay, yeah, it's been a wonderful day. We've discussed two very important things. Yes, Lymphatic filariasis is one of those neglected tropical diseases that they try and bring in time to time in the exam, see whether we've been reading in and around about it. Of course, we know that DM can come in so many facets. This is just one of the ways it would come in form of discussing a complication. And just to add to the discussion we had earlier when we were talking about foot care, it's important to try and classify the foot care you are doing, okay? So that it makes you say less. You say less, but it sounds like you're saying more. That's what I mean to say. So it's good to classify it into care of the foot, care of the foot gear meaning shoes or anything that covers the foot, and then care of the foot surrounding. If we can classify it into those three, and then just mention things in and around each of those three, then it will be covered. Okay, but there's a tendency for people to talk more about care of the foot and forget the foot gear and the foot surrounding. Okay, so please just try and classify it like that. It makes better sense. Yes, I'll put up the notice for the dissertation presentation today. We have 2 presenters already that have been chosen and they've been contacted and they've shown that they are willing. And I would advise that everyone doesn't miss this weekend's dissertation presentation because our 2 reviewers are the most seasoned of all our reviewers. And they both have agreed to review the books. Okay, so Dr. Remigos and Dr. Woko are the ones reviewing book this weekend. So I don't think any of you want to miss this weekend session. So please, let's come in on Saturday. So I'll put up the advert today and then we can pitch in on that. So I wish everybody a wonderful day. Let's keep doing our thing, keep reading and getting ready as well. Thank you, everyone.
Thank you, sir. Thank you, Dr. Ekele. Thank you, Dr. Kalamama. Thank you, our facilitators and our participants. We'll meet in class tomorrow. Thank you, Dr. Temitope. Thank you so much.
Thank you, Ma. Bye, everyone.
Thank you, Ma.